Assalamualaikum and a very good morning. So Dr. Kamil, how are you today?
Very good, very good. I tengah drinking coffee pot. Breakfast,
nice.
Breakfast at UMHealth.
Yes, okay. Bismillahirrahmanirrahim. Okay, my name is Dr. Firdaus Hariri. I'm the Deputy Dean of Research and Development from the Faculty of Dentistry. First of all, I would like to thank the team from Breakfast at UMHealth for the invitation. And today, we have with us Dr. Kamil Hassan, Dr. Muhammad Kamil Hassan, a colleague of mine from the Department of Oral and Maxillofacial Clinical Sciences, Faculty of Dentistry, as well as the Department of Oral and Maxillofacial, UMMC. So he will be sharing his experience with regards to jaw corrective surgery, aiming to bring us to the latest advancement in technology in that specific field, focusing on 3D surgical simulation, planning, and patient-specific implants. A little bit about Dr. Muhammad Kamil Hassan before I hand this session to him. He graduated with a Bachelor of Dental Surgery from Universiti College Cork, Ireland in 2012. He's quite old, actually. He then pursued his training in oral and maxillofacial surgery in the National Maxillofacial Unit of Ireland, St. James Hospital, Dublin. He completed his training with an MSc, Research in Oral Surgery, and subsequently awarded the Specialist Fellowship of Faculty of Dentistry, Royal College of Surgeons in Ireland in 2019. So he has this Irish accent later. I hope you all are okay with it. His research and clinical interests involve corrective jaw surgery, virtual surgical simulations, as well as finite element biomechanical analysis of maxillofacial regions. He has pioneered the virtual surgical planning for orthodontic surgery in the department, in the faculty, and working closely with a local 3D printing company, 3D Gens. But before we start, if you have any questions, feel free to type in at the Q&A box, and then I will read up to him at the end of his sharing. So without further ado, the floor is yours, Dr. Kamil.
Okay, thank you very much, Associate Prof. Dr. Firdaus. Very nice introduction. I do not have an Irish accent. Unfortunately, it's all gone. 3 years dah balik Malaysia. So let me just share my screen first, and then we'll get started from there. Okay. I'm going to do a slideshow. All right, I hope everyone can hear me well. Assalamualaikum and very good morning. It's practically our breakfast time, and breakfast at UMHealth is probably the best time to start your day. Especially coffee from Coffee Bot, Ep.40 UM. Again, my name is Dr. Kamil Hassan. Full name is Muhammad Kamil, but I can go with Kamil only. One of the oral and maxillofacial surgeons, and also lecturer in the Faculty of Dentistry, UM, also practicing in UMMC. So as what Prof. Firdaus had mentioned, what I'll be talking about today would be 3D computerized planning in corrective jaw surgery. All right, and I hope everyone can hear me well and enjoy the presentation. So basically an overview of what we'll go through today, or what I'll be talking about, is basically what are dental facial discrepancy or disproportion, and what are the issues related to this. What is corrective jaw surgery? What are the conventional planning methods that we've been doing all the while? The 3D planning experience that we have so far in UM, and although it's currently very, very new, and we'll share some clinical cases as well. A disclaimer, as with all presentations, all photos, radiographs, illustrations have been consented for use in this presentation. and also acknowledge the relevant authors or the keepers. As we will be sharing this talk with the medical colleagues in UMMC, I just want to explain what does oral and maxillofacial surgeons job scope basically. I cut out part of it because this is taken from the US myoms.org page. Anyways, we treat anything from the mouth, the teeth, third molars, trauma to the face, dental implant, extraction, treatment of oral head and neck cancer, OSA, cleft lip and palate, TMJ disease, facial pain, facial cosmetic surgery, and of course, corrective jaw surgery, which will be the main topic for today's presentation. So to introduce everyone to dentofacial disproportion or discrepancies is basically where our face is not in state of normal, but normal is quite subjective, isn't it? Proportion. So basically, if you say normal would be where your maxilla or your mid face is in front of your mandible and where your upper teeth bites in front of your lower teeth. And when you have disproportion or discrepancies, there's a multifactorial factors or causes behind it. If you look at the pictures here, there's three different individuals. All of them have somewhat a similar issue where the lower jaw looks prognatic or bigger or much more in front compared to the upper jaw. However, these three different individuals, they all have different causes of why the jaws are like that. So the disproportion or the discrepancies of the jaws can be either congenital, they're born with it, Pierre-Robin sequence, we see in the craniofacial clinic, craniofacial dysostosis, Apert syndrome, such as the boy on the upper left, Crouzons, patients with cleft lip and palate, such as this young man on the lower left. And because of his condition, his previous surgeries during his childhood, it has caused growth disturbances of the upper mid-face, the maxilla, and so on. But then some people, they don't have any issues at all, and it's just their own normal development in a way. Jaws can also be disproportion due to trauma or mismanagement of other dental issues, or even because of tumor ablative surgeries and so on. So, okay. And when you have dentofacial disproportion or discrepancies, there are issues that come with it as well. And the three main issues would be functional, aesthetics, and psychosocial. When we're talking about functional is where when the teeth are not in the ideal position, the occlusion or how the teeth bites makes it difficult for these individuals to chew efficiently. And when you cannot chew efficiently, you cannot eat proper food, take enough nutrition, and can result in malnutrition and so on. And also when the jaws are basically part of your upper airway, and if the jaws are less in growth, it can obstruct your upper airway, and these are seen in cases of severe mandibular retronacism or hypoplasia or mid-face hypoplasia as well. And because the jaws are not in a harmonious position, it also affects the facial features of these individuals. And this causes disharmony of your facial proportions and often results in an aesthetic issue or component as well. Patient will say, I don't like my lower jaw sticking out too much, or when I smile, I see less teeth, and so on. And then this results in a psychosocial issue as well. As kids growing up, just because they look slightly different than the others, they may be bullied, they have low self-esteem, which then can lead to other psychological conditions, depression, anxiety, and so on. So a lot of issues just from just from disproportion of the jaw relationship. So as oral and maxillofacial surgeons, how do we correct these problems? Of course, there are non-surgical management, but today we just talk about the surgical options. So corrective jaw surgery is the layman term. The proper or the formal term is orthognathic. Ortho being bone, gnathic is jaw, and surgery as surgery itself. Besides doing orthognathic surgery, you can also move the jaw with distraction osteogenesis. And distraction osteogenesis, we have our own expert here, Associate Prof. Firdaus, Hariri, which have done a lot of cases in our center. So on the lower left is basically a simulation of jaw corrective surgery using distraction osteogenesis, whereas on the lower right is a radiograph that compares pre and post surgery of correcting the lower jaw by pushing the lower jaw backwards with orthognathic surgery. Okay, so orthognathic surgery, the general overview is that it corrects the jaw position that is caused by the discrepancy of the maxilla and the mandible. And because either the issue is often not only one jaw, it can be a combination of both. Either jaws can be hypoplastic, small, retrognatic, or they can be either hypoplastic, prognatic, big, and so on. And there is often a combination of both. And these discrepancies is not only in one direction, but in all three dimensions, in your anterior, posterior, your vertical, and your transverse. And because of that, because it's actually a 3D kind of discrepancy, it requires detailed planning, measurements of facial proportions, taking study models, doing model surgery simulation, and so on. The movements, I can say that the movements when we do jaw surgery is not that much compared to probably other things, but it's in the millimeters. So that's why detailed planning is very, very important. Okay, so before we go on to our current technology with 3D planning and all that, we have to know how the conventional method actually works and conventional orthognathic surgery planning. So we have a patient here. It's the same patient I showed you earlier on, this young Chinese female adult complaining of basically a functional and also an aesthetic issue. Functional wise, her lower teeth are in front of her upper teeth. She cannot chew. She cannot bite on sandwiches. She cannot bite on pizzas. Just everything just slips out through the front. Cannot eat mee goreng or cannot bite using front teeth. And on the aesthetic issue, that she feels the lower jaw is in front and she has a longer face. So we look, we clock the patient as a whole, complaints, medical history, social history, and so on. And then when we get to the assessment point, we basically take clinical photos of the patient frontal profile and side profile. So the picture in the middle will show you these vertical lines and just trying to measure whether there's any parts within that horizontal dimension, whether there's any discrepancy, disproportion, asymmetry, and so on. When we look on the far right photo, the face is then divided into three areas: the upper face, mid face, and the lower face. And this, just from doing this, we can actually calculate what are the percentages where, if you say normal, they should all be equal, 1/3 of each. But in this patient, her lower anterior facial height is increased. We look inside the mouth, of course. We take intraoral photographs. We look at the teeth, the conditions of the teeth, the amount of teeth, any missing teeth, any pathologies, and so on. We look at the relationship of the upper teeth to the lower teeth. So this is what we call as a class 3, because the upper teeth is basically behind, the upper incisors are behind the lower incisors. The overjet is basically the overlapping of the upper to lower teeth in the AP dimension, and because of the patient is biting behind the lower incisors, she has a negative of 6 millimeters. The overbite is where the teeth overlaps in the vertical dimension, and again, because she's not biting with the lower teeth, there's no overbite there. Canting is basically whether there's any angulation of the upper jaw, and then center lines is where you want to make everything symmetrical. All right, so this is the pre-surgery intraoral photographs. And besides that, we have to take radiographs, and radiographs will include a lateral cephalometric view. This is not a lateral skull, it's actually a bit different. And from this lateral cephalometric view, we trace and we calculate certain angles, and these are like the angles of to determine the relationship of the jaws, the upper jaw or the lower jaw in relation to your skull base. And based on these calculations, we compare it to the value of our local population. So we don't compare it to Caucasians or Europeans or African Americans or even the Africans. So it's mostly of we now have studies that show us the values of our own local population. Okay, so again, once these values are basically just to inform us, just to give us more information to say, look, maybe the upper jaw is slightly backwards or retrognathic, or maybe the lower jaw is more in front, and so on. And following that, we start to plan the surgery in terms of how much we want to move the jaw. And this can be done both on this kind of tracing paper as well, where we do a prediction tracing, which is here on the right. And we say if we move the upper jaw forwards of, let's say, 5 millimeters and the lower jaw back 4, and so on, what would be the possible outcome? But again, these are all drawings. They can be used for the surgeons to plan the treatment, but often with drawings, they're not accurate, they're prone to errors, and so on. It can be shown to the patient, but it's hard for the patient to actually appreciate the drawing or the outcome of surgery just from a side profile. So then we have to transfer basically the patient's mouth, the teeth, onto a model, and this model is then mounted on this piece of hinge, which is called an articulator. And the articulator is basically representing the patient's teeth relationship, or the jaw relationship with their joint, their TMJ joint or their condyles. So basically, you're taking the patient's jaw outside, and when you take it outside on these models, you can just plan on the movements and planning the surgery. And this is basically called a model surgery. So there's a lot of work, a lot of steps with the conventional planning. But then, being said so, it's been used for a long time, many decades. It's relatively cheap, you just take x-rays, you use tracing papers, you pour impression and then put it with stone or aster. So it's basically a bit cheaper. Is it fast? Can be subjective. It depends on who does this work, depends on the lab, but relatively speaking, it is a bit faster. However, the disadvantages of the conventional planning is that when you transfer the patient to a model and so on, it's prone to error, prone to human error, lab error, material problems, loss of information within the study models, chipping of the cast in stone, wear and tear of plaster materials, and so on. So there's always the pros and cons. All right, so that's the conventional planning. So where have we come to? The year is 2021, and for the past 10 or 15 years, across the globe, people have moved on, surgeons have moved on to 3D virtual planning. So and with everything else that evolves in life, I think personally that digital and virtual planning is the future. Although I met a good number of surgeons who disagree, but it's okay. All right. Okay. We have software, we have computer engineers, we have programmers and all, and they are all there's already these softwares, a lot of softwares, open source or softwares or paid softwares with artificial intelligence that can help in virtual planning. And it's just as simple as forming a 3D reconstructed images. Probably the radiologist will know from your CT images, from your DICOM data. Right, so how do we do it? We take CT facial bones or a cone beam CT of the patient's head, different protocols for different types of CT. Of course, there's a mixed, what do you call that? Basically, which one do you want to use is based on preference of the surgeons or this engineer as well. So the data comes in very raw, very noisy, very rough looking, and it goes through a lot of post-processing editing, where everything just starts to smoothen out. The teeth looks a bit more defined in these areas, and when you reach to the final model, it basically looks like this, and then you have to separate the lower jaw from the upper jaw. So when you have that, we send it to our software engineers, and all the plans that we've done so far, that I've done so far, have been with 3D Gens, and this is a local company with, I think, with the first titanium 3D printer in Malaysia. So we have this, just choose different colors just to make sure that this is the mandible and this is the maxilla. Look all around the image. It's very nice. You don't need the patient to be there with you at all. And looking at this, then you can do your capillometric analysis. You can calculate all these angles that is already done conventionally as well, and you get all the information with just a CT scan. Following that, we then tell the software engineers or the technicians, look, for this patient, I want to move the jaw in a certain way, right? So normally in orthodontic surgery, with the upper jaw, it's a Lee-Ford 1. So there's Lee-Ford 1, 2, and 3, and Lee-Ford 1 is just on the upper jaw above the roots of the teeth, below your infraorbital rims, and so on. So this patient here has an asymmetry of the jaws. So we want to move the upper jaw downwards a bit and say, look, move it about 3 millimeters or so, and they cut using the software. They simulated it for me and said, okay, that's it. And next is, okay, now we want to move the lower jaw. Where do I want to put the lower jaw? I don't need a model for this. I just say, look, we do a BSSO, which is a bilateral sagittal split, sagittal, bilateral on both sides, osteotomy. And okay, put the lower jaw in the best position. That means in a class 1, or where the teeth meet, where the upper teeth bites in front of the lower teeth, and that's it. So that's the result of your virtual planning. You see it straight away. When you compare this to actually an articulator or the conventional method, it's that you don't see the eyes, you don't see the nose, you don't see the other relationship of the face, the jaw to the face. Okay, so that is basically the outcome of the planning alone. Where does the planning go after that? You can do soft tissue analysis or soft tissue simulation as well. But with softwares, it's a bit difficult. You might get patients, it might get the wrong idea. The algorithm, I think, is not perfected yet 100% with soft tissue simulation, because soft tissue in humans, it's hard to predict. You've lived for 20, 30 years with your muscles in that kind of lengths and so on, and you move in the jaws in different positions. Do these soft tissue actually follow? We don't know. All right, so I want to share a quick video, and this is a video from 3D Gens. It's basically the whole planning sequence. If you don't mind, let me just. Very good. So after the planning, what we do is the planners or the engineers will design cutting guides, and this has to be done because we follow the plan, the virtual plan, and you need to follow the same cuts that was planned in the simulation to be transferred on the patient. Because if you don't, then these patient-specific implants that are designed later on will not fit. And this can all be done, you know, it's just a part of the process as well. This is towards the end of the process. And just printing this is just as easy as just clicking print of your documents with a normal printer. And of course, nowadays, these models are just meant for show purposes. We don't actually have to print the whole skull model, and that reduces the cost a lot. Okay, right. So as surgeons, we all like to show a bit of what happens in the operating room and how this jaw surgery actually is carried out. And of course, under general anesthesia, where we have very good anesthetists here, we need to tube through the nose because you cannot tube through the mouth, as that will interfere with the occlusion or the bite later on. The upper jaw, and in most corrective jaw surgery or orthodontic surgery, everything is done inside the mouth, and this is very aesthetic driven as well. There's no scars on the face or on the neck, unless for certain very few cases that require incisions on the skin. The upper jaw is exposed, the upper jaw is cut according to the plan. The upper jaw is then moved towards the planned position, and then followed by doing the lower jaw, putting the lower jaw back in its the final position that was planned, and that's basically it with orthodontic surgery. And now we're looking at pre and post surgery. What does corrective jaw surgery actually result in? So we see that again, the same patient I showed in the first few slides, this young Chinese lady. with increased lower anterior facial height. Now has surgery by moving the upper jaw forwards and moving the lower jaw backwards. And she has a much nicer facial proportion, quite equal now. And of course, the upper lip is now in front of the lower lip, good chin definition, and just a nice cheek prominence. And this makes her look younger. She has increase in confidence, and she's more importantly is that she's able to eat sandwiches, pizzas, and bite noodles with the front teeth. She is still undergoing treatment with our orthodontic colleagues, but she's nearly finished. Another surgery, another patient, which we did, was it pre-COVID? Again, similar facial features, similar facial disproportion. Lower jaw is in front of the upper jaw, flat mid face, looks a bit older for her age. Same issues, aesthetic wise, same issues, functional wise, cannot bite, cannot chew properly, low self-esteem, and so on. Following surgery, moving the upper jaw forwards, moving the lower jaw backwards. She has now a nicer facial proportion, slightly equal. For ladies, it's nice to have that bit of a sharper jawline. Her teeth is now, her upper teeth is now in front of her lower teeth. She has had the braces removed, and she also has had veneers done. So this is not the latest photo of her teeth. And that is the result of corrective jaw surgery. So again, the advantages of computerized planning would be it's anatomically accurate because you take a CT scan of the facial or the patient with very thin slices. Minimal information loss from transfer of plan to surgical execution, and this is thanks to the cutting guides, thanks to the patient-specific implants that is 3D printed. It's predictable. It shortens surgical time. Again, this is quite subjective. It depends if you do it with a lot of assistance or if it's a teaching case and so on. But when you say shortened surgical time, is that you don't have to plan your cuts. Your cuts are already guided. You don't have to bend your plates. Your plates are already pre-bended. So there's this minimal time of fussing around. However, with 3D computerized planning, relatively new, so that's why it's very, very expensive. If you take European companies, which will cost you about 50,000 ringgit for just a double jaw surgery, and the technical expertise as well. Not everyone can do it, and for surgeons, transferring your method from conventional to 3D will be new, and there's a certain learning curve. But if you do it routinely, then it just becomes second nature. So that's pretty much about 3D planning in corrective jaw surgery. I just want to share two cases before I end this, and these are craniofacial cases. Cases from Associate Prof. Dr. Firdaus, Prof. Dr. Zainal, and all the craniofacial team in UMMC, neurosurgery, Prof. Faisal, ENT, Dr. J, and so on. There's a lot of names in that team. So we have one craniofacial case here, and this is a young girl, and she has airway obstruction, upper airway obstruction, because her lower jaw is basically protruded. And why? Because she has bilateral TMJ ankylosis. Her condyles, her joints are all ankylosed, and she cannot move the jaw, causing the jaw to be slow in growth, or basically just has regressed. So again, from a CT scan, you can do analysis of jaw relationship. You can calculate the angles and so on. And not only that, you can do an airway assessment as well. So in this particular patient, we have obliteration of the oropharynx. So she has upper airway obstruction there. And the tongue is pushed back because the lower jaw is very, very protruded. And following that, the conventional surgical simulation for these cases is to print a model. Print a model, apply the device, and then simulate it and advance it in a certain distance. But again, with the 3D planning, I don't have the photos. You can actually simulate that within the software alone without printing, without the need to print. You plan and design the cutting guide to make sure that the surgery itself is accurate, follows the virtual simulation. Carrying out the surgery, applying the distraction device, and after that, look at the changes that the patient has had throughout the whole treatment, from a very retruded jaw, you cannot even see the chin, until the chin has actually emerged and a very nice facial profile has been obtained. And finally, another case, and remember this boy from the beginning, Apert syndrome with mid-face deficiency and very, I think, severe OSA as well. With the CT scan, airway assessment is part of it. This obstruction at the nasopharynx level, and this, however, in the mandible seems okay, right? And so we know the main issue here is the mid-face. And when we want to correct the mid-face, correct the jaws as well. So we do a Lefort 3 rather than a Lefort 1. A Lefort 3 advancement, which involves the orbit sockets, moving everything forwards and simulating that to reach our desired outcome for the patient. Sorry, we don't have any photos on that. However, that's the end of my presentation. I'd like to acknowledge all the patients who consented to share the clinical photos for this presentation, and to all who are listening. Benji Lau, Dr. Benji Lau is our final year master student for the 3D planning photos. Again, to the craniofacial team headed by Associate Prof. Dr. Firdaus Hariri, Dr. Zainal Arif, all the UMHealth craniofacial team, neurosurgery, ENT, Optal for allowing to share their cases. And finally, to 3D Gens who have been assisting with the planning, printing, and the execution of the surgeries. Thank you very much, and thanks for listening. I hope you enjoyed a bit of the presentation.
Thank you. Thank you very much, Dr. Kamil. So we have quite a number of questions here, and we have about 15 to 20 minutes. So without wasting further time, I will just read all the questions. I'll start with the first one. Hi, what was the name of your 3D engineers again? Okay, it's 3D Gens. Okay, 3D Gens, Prof. Okay. Okay. Second questions. So, Dr. Kamil, do you have a 3D printing lab in the faculty?
No, we don't. We are planning to. I mean, it'd be really good if we have our own in-house 3D printers. But at the moment, we do not have any 3D printing printers in our faculty. However, 3D Gens does have their own dedicated space in our faculty. But I think Prof. Firdaus, they've all moved to the headquarters in Kejilutong.
Yes. Okay. All right. Hopefully, we can plan for printing lab soon. Probably a multidisciplinary printing lab. Yeah, Dr. Kamil.
Yes. Yes.
Okay. And then the next questions. There are nerves, vital structures, etc. in there. Can IT help avoiding them?
Yes, we do detect nerves a lot, especially when we take CBCT. These softwares, like I said, are all AI driven, and you just click on a button to locate the nerve, and immediately it comes out the nerve, right? Prof. Firdaus, the direction of the nerves. In corrective jaw surgery, the main nerves that we are concerned about will be the trigeminal nerve, the CN5. So the mandibular, we have the inferior alveolar nerve or the mandibular nerve, and in the maxilla would be the infraorbital nerves coming just at the infraorbital region.
Yes, and to add to that, in complex craniofacial cases where the osteotomy is near to vital structures such as the brain and the globes, the eye globes, the technology helps towards precisions of the osteotomy. All right. So the next question is on material. What biocompatible material do you use? I believe this is focused on the patient-specific implant, Dr. Kamil. Yeah.
Yes, yes. So the material is always titanium alloy. I don't know the specific type of alloy that they use, but it's definitely a titanium alloy. And 3D Gens have received what do you call that? The safety.
Malaysian
Yeah.
device accreditation, right?
Yes, Malaysian device accreditation to use those 3D printed materials.
Yeah.
Yeah.
Okay.
And they're all biocompatible, definitely.
Yeah. And a question on soft tissue.
Nose is
focusing,
wider.
yes, on the nose.
Yes. Prof. Tunku, is it? Prof. Tunku Sara. Yes. When we move the maxilla, when you move the maxilla, regardless of where you move it, the degloving of the soft tissues will then result in loss of attachment temporarily, right? But often we see this when we've moved the upper jaw, the maxilla forwards or upwards, there will be widening of the nose, and patients are informed of this. There will be changes in the nose, whether there's tipping of the nose or widening of the ala base is part of the surgical outcome. But then again, it does come together with the whole surgery, and the outcome is usually quite nice, despite of widening of the nose. We do have surgical techniques where, you know, like ala cinch, or we have to suture the septum back onto the maxilla to minimize these changes, but patients are aware and informed of the changes of the soft tissues afterwards.
Okay, all right, thanks, Dr. Kamil. The next one, using 3D printing for planning may be well and good, but seems a waste unless there are major anomalies, which may be difficult to correct and options need to be explored. So what's your opinion, Dr. Kamil?
Agree and disagree. So yes, they're very good. You visualize everything just from a CT scan, which is reconstructed into a 3D image. Is it a waste? Subjective. Some patients want to see what will happen to them in the surgery. They want to visualize it, which you cannot do with conventional planning. You can show them the model, oh, your teeth will be like this, but then they cannot appreciate the whole outcome of the face. Major anomalies, again, subjective. The corrective jaw surgery, even the slightest discrepancy of a jaw is upper or lower can be major to the patient. For surgeons, it might just be something routine. But again, it's sometimes it has to be patient driven as well. It's difficult to correct. Like I said, corrective jaw surgery, we work in millimeters. And if you don't get that accuracy of millimeters, then yeah, then the outcome would be affected as well.
Yeah, and adding to this issue, but I have to agree, 3D printing should instead be better utilized for printing of implants with biocompatible material. Yep, definitely.
Correct.
And the next one, what are veneers, Dr.
What are
Kamil?
veneers? I wish my restorative or prosto colleagues were here. Veneers are basically tooth-colored materials that are placed on your teeth to, I guess, to enhance or to make it look nicer. If that is the layman's term of veneers, and should be done properly with the dentist. Those fake veneers, those white-colored, Mentos-colored candies that we see on social media.
Oh yeah. In fact, the next question comes from a restorative specialist, Associate Prof. Shamsul. But he mentioned that about time we invest in cone beam CT and facial scan. Totally agree.
Totally agree.
And as well as the next one is about a proper software. 3D printers appears optional in planning. Definitely agree. All right. So, okay. Case 1. What happened to the ankylosed TMJ?
What happened to the ankylosed TMJ? Quite recent, wasn't it, Prof. Firdaus, that we went in and myself and Dato Prof. Firdaus, our fellow came in, and what we do was we had to release the TMJ. So we did resection of the ankylotic mass through a bilateral Al-Khayyat Brahmi incision, which is just in front of the ear. So we resected the mass, the ankylosis mass. We repaired the lining with temporalis fascia, and we also had to remove the coronoid process of the mandible as well to increase the opening of the mouth. And currently she's doing quite well. And we removed the distraction device as well, which has been there for quite a while and had recurrent infections.
Yes. Okay. Thank you, Dr. Kamil. I'm not sure whether this question is for Dr. Kamil or in a bigger view to the university, because the question asked about the 3D printer that the university has invested some years ago. But if I can,
I don't know the answer.
yeah, I'm not sure. But our faculty of dentistry, we never had one. But then again, we have an MOU with 3D Gens where they actually park their 3D printers in one of our labs. But then again, COVID happens. So now those printers are back in their headquarters in Bukit Jelutong. Yeah. So I'm not sure, but I'm sure there are printers in few faculties and departments. I think I've seen quite a number of printers in Faculty of Engineering. In fact, we had a couple of research projects with them. And the last one, because I think no more. From Prof. Ishamsul as well. So the treatment plan finalization, 3D gens or surgeons?
Oh, definitely surgeons.
Oh yeah, definitely surgeons.
Definitely is surgeon driven. I have to say 3D gens is relatively or quite new in this with orthodontic surgery. I mean, they've done a lot of neuro cases. They've done a lot of mandibular recon and all that. But for orthodontic surgery, it's quite new. If I am not mistaken, about 10 to 15 cases only. But again, it's surgeon driven with the final treatment outcome, treatment plan.
Yeah. And then yes, thank you, Dr. Shams. There is a new 3D printing lab opposite Medicafe. New one, baru.
Awesome.
And yes, and a few and then what else? I think that's more or less about it. Probably a last question from me, because I can see a lot of processes throughout the surgical planning, Dr. Kamil. So research collaboration, multidisciplinary research collaboration. What do you think?
Potential? Oh, definitely. There's a lot of things to do. There's a lot of things to do in terms of research. It can start from as easy as the planning itself. Then you can move on to biomechanical analysis. You can move on to materials. Now 3D Gens is also like other 3D companies, medical 3D companies printing. I cannot remember the name. Membranes, biocompatible membranes. It's not only just metal. It's also soft tissue as well. Research-wise, I guess it's endless lah, Prof. Banyak sangat that we can actually do. Collaboration between specialties. If it's within the surgical specialties, definitely. Also, any of the hard tissue specialties, ortho, neuro, max fax, soft tissue with 3D planning as well. Plastics, ENT, whoever does the nose, whoever does the face. It's endless. It's endless. There's a lot of things to work on.
Yes. Okay. I think that's wrapped up the session. Congrats, Dr. Kamil, and thank you, Dr. Kamil, for a very nicely presented sharing. And once again, thank you very much to Breakfast UMHealth team And I guess we will see everybody again, same day, same time next week. Okay, thank you everybody. Stay safe.
Thank you very much.
Have a good day.
Have a good breakfast. All right.